Hello, welcome all at this webinar, EMTIC webinar, a smart patch from home to design, in which we would like to share some experience on our recent developments on monitoring at the home situation and the project we did in a collaboration with the TU and Philips research. First, I have some organizational remarks to make. All microphones should be on mute. However, there is an opportunity to ask questions after every presentation. Questions can be asked via unmuting the mic, or you can ask them via the chat. We have a nice program, and I will start with giving a short introduction, because we could also have made the title of this webinar, The Future of Monitoring Vital Parameters, Continuous and Remote. It's an exciting time. A lot of possibilities arise. As I said, it is a project that is done within the EMTIC collaboration, which is a collaboration with partners in the Eindhoven region. And one of the purposes of EMTIC is to translate high-tech healthcare innovation fast and implement them fast into the healthcare system. And we would like to share some insights of a project which we did, and you can choose whether we succeeded in this purpose of EMTIC. First, this project concerns a part of the perioperative care, and I would like to introduce you a little bit on perioperative care. What it is the care for patients that will undergo a surgical operation, and in the Netherlands it's 1.3 million operations each year. And if you the reported mortality of that around these operations is about 1.9%. That means that annual mortality is about 12,000 patients each year, and then on top of that, complications. I didn't take that into account in these numbers. So it's a large area of the healthcare system. What is special about that? That deterioration in the perioperative period often goes unnoticed, and what it was discovered is that although the complication rate and the major complication rate between hospitals is more or less the same, there can be a difference between hospitals in outcome after these complications. So with that, you can call failure to rescue after a complication. And what is noted is that that here at this time point where the fatal incident happens, long before an acute process is already started, and the signs of deterioration already arise at this time point. Early warning systems has been developed, in which the signs of deterioration are recognized more, and there is responding teams that take care of the patient at risk. However, in the recognition and screening and triggers of the rapid response team, improvements can be made. Are these fatalities preventable, and is early warning score useful? Here you can see that patients have higher early warning scores before the time of their code blue situation. As I said, times are changing, and here the current situation is that monitoring vital parameters are continuously monitored in the OR and the intensive care unit. At the ward, there are spot checks. At certain times, vital parameters are measured, and there is no monitoring of vital parameters in the home situation. And the current developments allow with systems of remote monitoring that in all areas of the perioperative care or the care location of the patient, that continuous monitoring of vital parameters is feasible. And also in the COVID pandemic, it was shown a lot of attention arised for the value of e-health and telemonitoring, but still it proved that telemonitoring and e-health remains a challenge. And is continuous monitoring on a ward effective? Here you see a study, it's a relative old study where they implemented pulse oximetry, continuous pulse oximetry at the ward, and there you see afterwards that there is a reduction of ICU admissions. So these authors concluded that there is indeed an effect of continuous monitoring on the ward. And this is the aim of our research line in this area, is that we would like to develop clinical decision support systems with new monitoring modalities, smart algorithms that are implemented in workflow. And we would like to share some thoughts on a recent development with you today. So here is the program. First, Jonna van der Stam will tell you something on the TRICA study, in which we show some data on validation of a remote patch. Lisa van Ede, she will talk about the PEACH trial, in which we used the HealtDot in a care path, and the session is closed by Simon Nienhuis, who will talk about the benefits and challenges on continuous monitoring in the clinical care path and some future perspectives. And now I will give the floor to Jonna van der Stam.
Thank you, Arthur. Indeed, I'm going to discuss the TRICA trial, so the transitional care trial that we did in our hospital. Well, transitional care stands for the care from hospital to home. So from the moment the patient comes out of the operating room till the moment he is at home recovering. Now, as Arthur already stated, the current situation is that patients are continuously monitored in the intensive care unit of post-anesthesia care unit, where we have these patient monitors and the nursing staff is constantly checking their vital parameters to see if they're recovering well. If the patient is stable enough to go to the general ward, this level of monitoring is reduced to only spot checks. As Arthur said, the early warning scores are used, where the nursing staff measures a few vital parameters, approximately 3 times a day, and based on the resulting score, an acute care team can be alerted. When a patient is recovered enough to go home, we send them home and we no longer monitor vital parameters at all. And the goal of this transitional care trial is to see if we can use a smart sensor that's wearable, that can measure continuously, to monitor patients during this entire trajectory, but also at home. Well, the sensor we use is the HealtDot. It's a small wearable patch sensor. It measures heart and respiration rate, and it wirelessly sends the vital parameters every 5 minutes. So you could real-time monitor patients with this device. It can be worn for up to 2 weeks. So for most postoperative patients, this means the period in the hospital will also the period at home for a part. What we did in this trial is we asked a total of 350 patients to wear this HealtDot postoperatively. We applied it the moment they arrived in the intensive care unit or recovery room. So we started immediately after surgery, and then the 2 weeks in which the patient was first in this high care unit, then in the general ward receiving only spot checks, and then also a part at home where we normally wouldn't have any data. And the aims of this trial were twofold. First, to assess the accuracy, so the vital parameters that are measured using that HealtDot, are they accurate enough to use in the clinical setting? And the second part is the early warning score potential. So can we actually do something with these vitals? Because in the current day, it's easy to create more and more data, but the goal is also to create useful data. Now, first, I'll discuss the accuracy a bit. And how do you assess accuracy of such a wearable device? You compare it to gold standard reference equipment. So in our case, the monitoring equipment in the recovery room and the intensive care unit that are just used as part of routine care. So we real-time logged this data for a subset of the patient, and we log the ECG signal, in order to extract the heart rate, and the capnography signal, so the exhaled carbon dioxide signal, to find the respiratory rate, so we could make a comparison between the vitals measured by the HealtDot, so the patch we applied, and the measured vitals by the reference monitor at the same time. Now, we distinguish two populations because surgery is, of course, a wide field. We only studied abdominal surgery patients, and there we have two subgroups. The bariatric surgery, patients with a relatively high BMI, very short surgery duration. They also only stay in the hospital for a short time, usually only until the next morning, and they are always monitored in the recovery room after surgery. Then the other group is the major abdominal cancer surgery. These patients suffer from cancer. They have a longer surgery duration. The surgeries can be half a day up to a whole day of surgery, and they stay in the hospital for a longer time, typically a week, but can be up to 2 weeks. They're often monitored in the intensive care unit and in some cases in the recovery room immediately after surgery, but mostly in the intensive care unit. So we first look into the accuracy in the bariatric group. And there we compared to the reference monitor in the post-anesthesia care unit. Here you see a blunt Almond plot where you see almost all points are nicely around the 0 in the middle, so the big cloud of points, which is where you would like all your data to be. And only if a small set of the points show a big difference between the two measurement techniques. Then if we look in the table, we see that on 1 second base, so if you compare data from both devices every second, we get approximately 90% of the means within the desired range. But then we also looked at the downsampled data, so data per 5 minutes. And we did that because, as I said in the beginning, the device is meant to monitor patients remotely, not every second, but to transmit data to the cloud every 5 minutes. So in clinical practice, you wouldn't be looking at the 1 second data, you'd be looking at the 5 minutes. And there we see an increase in the performance, so till 90.5% for both the mean and confidence intervals within the desired threshold for heart rate. Now, and if we then look at the cloud of points, where you see quite a big difference, they originate from a few patients where for a short time the HealtDot does not measure the same value as the patient monitor, but quite a higher rate. And that's probably caused by some other motions that are detected by the HealtDot. But as you see, it's only for a short amount of time, and as it's only a subset of the data, we find it acceptable. And for many patients, we also see this very nice pattern that we see in the other graph, where it just nicely follows the reference. If we then look at the respiration rate, we see a bit bigger cloud, but all points in the cloud around 0, so not a big difference for a small subset of patients. And then again, we see that the performance is okay for the 1 second averages, but really improves if we look at 5 minutes. And in the end, the 5-minute data is the data we're interested in this device. Then if we look at the major abdominal cancer surgery patients, so the patients that were a bit more, had a more extensive surgery. So we look at the blunt Almond plot again. Here the color indicates the amount of dots that are in a certain space. So we see that the large majority of the dots are located around the 0, so the place where you want to be. And the farther away from the 0 difference you get, the lighter the color becomes, so the less data points are there. Then we again looked first at the 1 second data, and then we see that already almost 100% of the heart rate measurements are within the 5 beats per minute. That's in the guidelines that you want all your data to be, or at least sufficient data to be. And for respiration rate, we get almost 90% within these 3 breaths per minute, which is the number we're aiming for. If we then downsample to the 5-minute data, we increase to around 95% for both. So that's a very nice result. Then we also took it a step further and did not only look at the differences between the two measurements, but also at what would these differences mean. Because a small difference in a measurement can not really have a lot of impact in your clinical practice if it doesn't cross the boundaries on which you would act to change protocols for a patient, for instance. But if you cross certain cutoff values and thereby you trigger follow-up care, then of course it's very important that you don't mismeasure there. So the Clarke error grid was originally proposed for glucose measurements. There it's of course very intuitive. If your old sensor or your gold standard sensor says that the patient's sugar is too high, but your new sensor says it's too low, then you don't want to start giving the patient sugar, because then you're only making the problem worse, because the sugar was already too high. You're making it even higher, and vice versa, of course. So it's very important that you don't really mix up the areas where the patients are in. For heart rate, that's the same. If you measure a heart rate that's way too high, while it's actually too low, you could give medications that give the opposite result of the result you're aiming for. So that's why the Clarke error grid can also be modified a bit to use for heart or respiration rate, where you place the cutoffs on the cutoff values that are used in the early warning scores. And then you can see if the clinical outcome of a difference in measurement would be different or not. Then zone A and B are the areas where you want to be, because there no difference in treatment would occur. And then C, D, and A are the areas that you would like to avoid, because there potentially different treatment could occur. If we look at the per second data, we see that for heart rate, all data is in zone A and B. So that's what we were hoping to see. And for respiration rate, we see again this big cloud where the majority of the points, so the most dark areas, are around the axis with no difference. And we already have almost 89% of the data in zones A and B. So that's already nice. But if we then downsample to the 5-minute data, the data we'd be using in the clinical practice, we see still 100% of the data for heart rate within these clinically acceptable zones, but also more than 99% of the data for respiration rate is in these zones. So that means that we could use it without causing any differences in treatment. So now we've looked a bit at the accuracy into a different population, and I'll shortly want to talk a bit about the next step. What could you do with the data? So towards the wearable-based early warning score to complement or partly replace the early warning scores that are currently performed manually, because they're very time invasive. Nursing staff needs to do it 3 times a day for all patients, so that adds up to a lot of work. And of course, it would be great if we can partly reduce that workload safely with a similar performance. So we made a comparable remote early warning score based on the heart and respiration rate measured by this HealtDot. And we see the dark blue area under the curve matches the MUSE, so the modified early warning score that's currently used in clinical practice. And the dot then indicates the cutoff point that we would use in the clinic. So we can make a remote early warning score with a similar performance in our population, which is a nice first step to see whether it would be feasible to use this HealtDot in the clinic. And then we also looked at different levels of the early warning score with the cutoffs that are used. And if we then place the cutoff with the dashed line for the RUSE, then we match the amount of true positives we find. So we can create an early warning score that's similar in performance. Of course, we can discuss later where the optimal cutoff point should be placed to optimally serve the clinical practice, but it's a nice first insight. Then I would like to end my presentation with a bit of accuracy of the HealtDot to use it in the clinic, and also a hint at the things you could do with it in the clinic, but Lisa is going to go into that a lot more.
Jonna, thank you very much for this presentation, very insightful. I think we have room for some questions. I don't know if in the audience, the participants have a question. You can unmute yourself and identify yourself, state your name, and ask a question. And you also can ask via the chat a question. But if there are, just wait a second. But I can start with a question, Jonna, for you. You presented the study for the accuracy, and it seemed all very smoothly. But did you also encounter difficulties by using a patch in the clinical situations, and which challenges did you encounter?
Well, for this trial, the challenges were limited. It's very easy to apply the device. You only have to apply it to the left lower rib, which is quite easy to find, and you only need to stick the patch on, so very easy. In this trial, we did do it, analyze the data retrospectively, so you couldn't follow the patients real time. So perhaps Lisa can discuss if that had any problems later.
Okay, thank you. And I see that there is a question from the audience. Nicole asks, let's see, can we understand where the cloud of dots in the bottom right comes from?
Well, we of course have some hypotheses, but we cannot give a conclusive result on that yet. But the patch measures the movement of the heart, and you can of course imagine that with all the movements going on in the body and also the heart beating 2 times per actual heartbeat, that there could be some noise from the movements that is picked up as a heart rate where it shouldn't have been. But it's only in a limited number of points.
Yeah, so in fact, would you say it's an artifact and it's a double count?
Yes,
And,
potentially.
Yeah. Let's see, there's another question. Case asks, how does the HealtDot connect to cloud via Wi-Fi via the Wi-Fi of patients? I think that's an interesting question.
Yes. It uses the LoRa network, so a network that's available for the entire Netherlands. So the patient does not have to match it to its phone or its Wi-Fi at home. And the patient doesn't need to stay at home in order to be monitored. He can just go about his normal day, go for a trip around the block without losing signal.
Yeah. How was the connectivity during the trial? Did you experience any problems?
Well, we didn't use the real-time data because it was still an investigational device in the TRICA trial, so I don't have the exact data.
Oh, okay, okay. Let's see. There are no more questions. Thank you, Jonna.
Yes, thank you.
I think we can continue with the next presentation. And the next presentation is Lisa van Ede will do the next presentation on post-bariatric early discharge controlled by HealtDot. And it's a preference-based randomized controlled trial. So the floor is yours.
Thank you, Arthur, for your introduction. Yeah, next to my slides. Welcome all. My name is Lisa and I'm a PhD candidate also here in Catharina Hospital. I will tell you something about the PEACH trial we performed here. And this is shortage for post-bariatric early discharge controlled by HealtDot. And this multidisciplinary enthusiastic team was involved in the study here on the site, and the names are mentioned in the box below. So bariatric surgery, a short explanation, is surgery of the stomach for patients living with morbid obesity or obesity with metabolic diseases, just to help them losing weight. And those are the two most common types of bariatric surgery. And on the right side, you see the sleeve gastrectomy, and on the left side, you see the Roux-en-Y gastric bypass. And the last couple of years, the amount of bariatric surgeries performed is increasingly worldwide. And so is the techniques from the surgeon and the anesthesiologist improved, which has resulted, among other things, to a shorter length of stay in the hospital. And these improvements have led that some centers already perform bariatric surgery in an outpatient recovery pathway, which means that the patients were discharged on the same day after the surgery and recover at home. There are several retrospective studies performed proving the feasibility and the safety of this outpatient recovery pathway. However, this is not implemented widely yet. And yeah, there are several reasons what explain this, but the most common reason is there remain concerns about not being able to timely detect post-operative complications when the patient is at home in a surrounding where it's not monitored and not supervised, as you can see in the figure. But it's questionable whether the patient is so much more monitored when he stays in the hospital, as there are also large parts of the days the patient is not supervised and not monitored, especially at night. And if a clinical deterioration occurs in that time, it can also be missed by clinicians. So the continuous and remote monitoring can provide a solution for this. The monitoring can fill the unmonitored gaps, but also the higher measurement density allows us to see more subtle changes within the vital parameters. And these changes can also be indicative for postoperative complications. And the two most feared complications in this type of surgery are the postoperative bleeding or the anastomotic leakage. The HealtDot, yeah, we know all about it now from Jonna, but I will repeat it shortly. It's a wearable patch which can be attached under the left lower rib, and it measures the heart rate, the respiratory rate, body position, and body activity of the patients. And every 5 minutes, the average of the values is transmitted wirelessly to a dashboard, the Guardian. And in this dashboard, the vital parameters become visible in like a trend figure. I will show some examples later. The Guardian dashboard is supported with the software, with the notification or alarming protocol. And as the continuous monitoring in the medical field is quite new at the moment, the guidelines and protocols would tell you how to make such notification protocol and how to integrate such monitoring systems within your work field are very scarce. So actually we had to invent the wheel for ourselves for this study. And we did so by a literature research. We looked for normal and abnormal vital signs indicative for the postoperative complications. And the literature we used, we assessed it in the expert sessions. However, the literature was very, very scarcely available. So we also needed to use our expert opinion on it. Also, in these expert sessions, we developed different threshold protocols, so different early warning score protocols. And these protocols we tested on the data obtained from the TRICA trial, the data from Jonna's presentation. So shortly, the literature told us that the heart rate in a bleeding event, the tachycardia which occurs, its onset is within 8 hours after the surgery, most of the times, and it can reach a maximum heart value between the 100 and 120 beats per minute. And for anastomotic leakage, it is a little bit later, the onset, and the maximum can reach a higher value above the 120 beats per minute. So that's a little difference between the two complications. And of respiratory data, there was not much literature available, but suggested is that in anastomotic leakage, the respiratory distress is more common than in patients with a bleeding event. This is an example of an early warning score protocol we had to develop. And yeah, Jonna called it the ruse. I placed a C before the ruse to make it continuous and remote monitoring. And in the right panel, you see the different risk zones, which can be assigned to the clinical condition of the patient and which can generate notifications. And the risk zones do depend on whether or not the thresholds in the left panel are exceeded. And as you can see, the thresholds had to be established by us, but also we had to value the thresholds to a certain amount of risk points, like the 0, the 1, and the 2. You can imagine if the patient walks up the stairs, the heart rate rises and a notification can be generated, but we want to avoid those false notifications to prevent alarm burden of the nurses. And therefore we invented the reassurance time and the baseline times. And the reassurance time of 15 minutes means that the risk zone had to be elevated for at least 15 minutes in a row, and then a notification can be generated. So if this period is shorter, no notification is made. And the baseline time means that the risk zone had to be lower for another 15 minutes in a row, and after that a new notification can be generated, just to when two complications happen in one patient, they can be divided. These are the results of the different threshold protocols. In the purple box you see the different protocols used. And in the orange box, you can see the most optimal protocol with the highest sensitivity and the highest alarm silence. And this is the final result of the CRUISE, the early warning score protocol we used in the PEACH study. So in the PEACH study, we assessed whether a new outpatient recovery pathway with remote monitoring was non-inferior to the standard current recovery pathway. And this is discharge on postoperative day 1 without remote monitoring. And we tested the non-inferiority using a combined textbook outcome. This includes mortality, severe complications, readmission, mild complications, and prolonged hospital admission. And almost every patient undergoing elective primary surgery of either sleeve gastrectomy or gastric bypass was included, except for those who live alone or were allergic to white plasters. So the PEACH study was a patient preference trial. In the current work field, a patient-centered approach is very important, and especially in bariatric patients, their autonomy and participation in their trajectory is super important for better results. So we asked the patient whether they wanted to participate in the remote group or in the standard group. And if they had no preference, the patients were randomized. And eventually, each group would contain 100 patients each. So the patients in the remote group underwent surgery, and directly after the surgery, the HealtDot was attached. And the same day, the patient was discharged under the discretion of a nurse, but only if the patient was still willing to go home, and when the patient received clinical approval. The next day, a telephone consultation was scheduled, and the alarms of the notification system, the Guardian, was checked on a daily basis. So we chose not to have active alarms. We could only see the notifications when logged into the system, and we checked for that for 7 days after the surgery, and every day we could check retrospectively about the last 24 hours. And 7 days after the surgery, the patients of all groups completed the satisfaction questionnaire. So I will show you some preliminary results of the study. At the moment, the study is already finished, and at the moment of the preliminary results, all patients were included, and we saw that all patients, almost all patients, had a clear preference for their recovery pathway. So there were approximately 3 patients who were randomized, and luckily for us, the distribution was equally. There were no major differences between the study groups concerning the complications. Mortality was 0 in both groups, and minor complication occurred in each group once. And in the remote monitoring group, there happened 2 major complications in patients requiring resurgery. However, these surgeries happened on the 2nd day after the first initial surgery, so it didn't have to do with the early discharge. Of the first 50 patients in the remote monitoring group, 70% succeeded to go home of the day of the surgery. That means that 30% of those patients did stay in the hospital for at least 1 night, and the total amount of nights the patients together stayed in the hospital were 21. And in the standard group, of the 50 patients, 88% succeeded to be discharged at the day after the surgery. That means that 12% stayed longer than 2 nights or longer. And that total amount of nights was 56. So that is, that doubles your whole hospital admission nights. And the patients were equally satisfied with the care they received. So I have some examples of the HealtDot in work. There are different examples on how the HealtDot can be used within your clinical workflow. This first example is a false alarm. This is the data we get to see when we log into the system. And what you see, the red line is the heart rate, the green line is the respiratory rate, and the blue line is activity of the patient. And this course of vital parameters is a normal postoperative course. And the patient went home the day of the surgery, and after the second day of the surgery, you see that the notification was generated. That's the orange arrow in the upper bar. And the next day, we called the patient per protocol and asked if he was doing fine. And the patient said, "Oh yeah, I'm doing fine. I actually don't know what I was doing," or at least he didn't want to share with us what he was doing. But this is an example of a false alarm. This is an example how the HealtDot could support clinical decision-making in hospital. The patient stayed within the hospital after the surgery because of a higher heart rate. You can also see that the notification was generated in the evening because of the heart rate. And the day after, the patient stayed in the hospital for further observation, and the spot checks were performed. And in the second spot check, the heart rate was also above the 100. So discuss was whether a re-intervention was needed. And I believe that when you use this HealtDot data, you have more sight on how the patient is doing, and it can support your clinical decision making more than you can do with literally one spot check. I have two more examples. In this example, a patient was cared on a remote basis. The patient went home the day after surgery, and the day after the surgery, we called her and she told us she experienced rectal blood loss. The vitals were normal. The patient was feeling all right, so we decided to leave the patient at home. And we had a few more contact moments, and then we closed the contact. The patient did not have to come back to the hospital for further examination. This last example is of a patient who went home the day of the surgery. The day afterwards, in the scheduled telephone consultation, the patient was doing fine. However, that night, the heart rate rose. And the second day, we checked per protocol the notification system, and we saw that the notification was generated. So we called the patient, but the patient already was readmitted to the hospital because she collapsed. We didn't use the active alarm, so we only could see it when logged into the system. So I think what we learned from this case is you can choose when you choose for active alarms, the patient could have been contacted more early and maybe could receive the care needed on an earlier basis. So the results I showed are promising for the implementation of the outpatient recovery pathway as a standard alternative. The patient had a clear preference for the recovery pathway. It is feasible and it helps your length of stay. We had some anecdotal evidence, as I showed, for the benefits of telemonitoring, in which clinicians are supported and the patients feel safe and are very pleased with it. So.
Thank you very much, Lisa, for your presentation and your clear overview of the study. Impressive results. There are some questions from the chat. The first one is from Kees. Does the HealtDot also measure temperature? Well, this is a short answer. No.
Yeah, it does not. It does not.
And Peter asked, this is. We talked also a lot about this. Did you consider using patient-specific thresholds for the crews, as baselines may be different, and that may enhance your false alarm or decrease your false alarm rate? Yeah, we did. We did talk about it, whether we should use the individual factors. There is an upcoming study for publication where we checked for if the beta blocker use affects your protocol. In the PEACH study, we have
not in the PEACE study, in the TRICA study, we have too few events to say something about the sensitivity of only the beta blockers when you include that in your protocol. But we did see that beta blockers did not influence the mean heart rate or the mean respiratory rate. So in that count, concerning beta blockers, you should not take account for it in your assessment. But for other individual factors, we didn't have an answer yet. So that's nice for further examination.
Yeah,
for the studies.
Yeah. So it would perhaps indeed be interesting to take baseline vital parameters into account, but that's for further for future studies. Another question is from Lian van der Laar, and she asked why we chose to check the notifications retrospectively, so every 24 hours instead of real time, and whether this is the procedure we would advise for potential standard care.
Yeah, I think like the examples I showed, the different trend lines can give more, we call body to your clinical decision making, and you can see over a longer period how the patient is doing. So that's for one. I don't know how to say it actually, but. What we learned from the last example I showed is that maybe using the active alarms will, might be better for the clinical pathway. But that's what we learned from doing our study.
Yeah, and one other aspect is that we aim to mimic the clinical care at home, and in the clinical situation. There's also no continuous monitoring in the hospital, and so, in fact, in the hospital, the vital parameters are also evaluated retrospectively. So it mostly mimics the clinical care as we do at the moment. But it would be very interesting to see whether we could have proactive real-time alarms. But that's indeed for future studies to investigate how to implement it in clinical practice. And there is one last question. It's from Nicole, and she asks whether you could attach the HealtDot already 3 days prior to surgery and to get a nice baseline of each patient.
Yes, that's possible for further future studies. The only thing is that the patient have to come back to the hospital for the attachment of the plaster, or we have to instruct the patients to do it themselves at home. That's also a possibility, but it's
The HealtDot is now recommended for use for about 14 days. So you could start prior to surgery. And
just a week afterwards,
until 14 days after surgery, and this is the last question. So thank you very much once again, and we will continue a little ahead of a little after on scheme, but I'm very happy to announce Simon Nienhuis, who will talk on the benefits and challenges to implement continuous monitoring technology in the clinical practice, and I'm very curious to the future perspectives.
Well, Arthur, thank you. Thank you for giving me the opportunity to give more or less the wrap-up of this session, and actually it starts a bit with the past. My name is Simon Nienhuis. I'm one of the surgeons with particular interest in bariatric surgery, and this is the only treatment with long-term results for this chronic disease, morbid obesity. And before Corona, we used to perform up to 1,000 procedures every year. And we have learned from the past that with protocols and dedication from the whole team, we could reduce the hospital stay. It used to be 4 or 5 days, and reduced it up to only 1 day and 1 night in hospital. However, even a further reduction did not seem to be possible, and furthermore, we had an increased rate of readmissions. People were going home, having questions, and came back to the hospital. So, already a few years ago, I had the idea that maybe we could use some kind of a wearable to help us further to reduce hospital stay and hopefully to prevent readmissions. And looking for possibilities, well, we encountered this kind of problems. As you've seen here, whether or not there was a connection problem with Bluetooth, or you had to handle with difficult questionnaires, finding the right solution wasn't possible. Fortunately, I encountered Arthur. He was bringing me good news from Philips with this HealtDot you've seen. And especially interesting for me as a clinician, the heart and breathing rate was important. And it was possible to use it for 14 days and measurements transmitted automatically. This I wanted to have in my clinical practice. So that was the onset, as you've heard. And I think this journey was such a success because it started with a clinically relevant question. We wanted to provide something to the patient to go home the same day and have the same convalescence at home. Of course, we had to go to the accuracy within the TRICA data Jonas showed us. Then we implemented it in a study, the PEACH trial. And to be honest, we were at the moment of finishing up the end results, and they're looking as promises as the preliminary results Lisa showed us. So we're coming towards the new standard. And with this new standard, we're hoping to provide this for every patient for bariatric surgery. However, to come to this new standard, I would like to point out 3 things. The implementation, finding new early warning scores, and something what has to do with the feeling of the nurses. First of all, implementation, shifting from all the help we have had from Philips and the Technical University towards standard care means new contracts. You have to think how to control. Maybe we are getting on top of this building just a room for real-time controlling all those patients with wearables at home, and how to bring the knowledge not only to those performing the study, but also those just working at the board. And it has forced us to think about what are the true discharge rules. I mean, you've seen from the examples how difficult it is to find the true thresholds. We already normally let people to go home. So we're now focused to have the reliable rules when we send the patients at home, that we can implement even, I would say, in an upgraded version of these early warning scores. And therefore, I think expanding this research to multi-center, finding platforms, and then with this hopefully more data, we will come to a even improved warning score. And another subsequent study we're looking for is that we not only do this for the patients as well as for the nurses. So upcoming next is a study where we use the HealtDot at our whole oncological surgical ward. And not only for the benefits of the patients, but also for the benefits of the nurse. To get more confidence and seeing this as a challenge as well, to improve their quality of work as well. I think as a conclusion, we're towards more data, and the availability of it by wearables are challenging, and they will help providing us answers for our clinical relevant questions, and may help the patients for self-support as well as nurses. And this exciting journey has not ended yet, and I'm looking forward to the future. Already greatly appreciated your attention, and we'll give the back to you, Arthur.
Simon, thank you very much to give a overview on the challenges and future perspectives. see whether there is a question from the audience. And Leon, she asks, let's see, if you propose the same day release combined with HealtDot monitoring to become the new standard, how would you deal with the 50 patients who prefer to stay at home, as found in Peach? That's really an interesting question, and I would like to add something on it. Do you know something about the background from people who do not want to go home?
Yeah, it is indeed an interesting question. Although, looking back the lessons we've learned from the past, with a lot of providing information, we already succeeded in decreasing the hospital stay from 5 to 1 day. So it has to do with information, education. And so I was already surprised that even without this information, already half of the patient group had already a preference to go home. And those who didn't, well, some have doubts about looking there, I would say, a larger distance. We receive patients from all parts of the Netherlands, and some have come from further abroad. And I think what I mean is the standard of care, probably this 50% will increase. And then, of course, there must always be room to give more personalized medicines. So this is not a solution for everybody, but in general, it will help us a lot to reduce all those what gives a burden to what we have in the hospital.
Well, that's a very promising last remark, and I'm getting instructions that we should round off because we are a little over time. I have another remark to make before I thank the audience for joining. That the session is recorded and will be distributed by the EMT communication channel, so everybody can review, see it again when interested. So I guess it will also be shared on the networks, and so. Please, you're invited to see it again for people who miss it. Leaving me to thank the speakers, Jonna van Stam, Lisa van Ede, and Simon Nienhuis, and I thank the audience for joining us in this interesting webinar. Have a nice afternoon.